Welcome everyone to the Sudanese Infectious Diseases Association monthly grand round. We're happy today to have Dr. Yasser Hamad with us. Dr. Yasser is an assistant professor of infectious diseases and critical care physician in the Division of Pulmonary Allergy, Critical Care and Sleep Medicine at the University of Minnesota. He is a triple board certified in internal medicine, infectious diseases, and critical care medicine with additional certification in tropical medicine and critical care echocardiography. Dr. Hamad received his medical degree from the University of Juba and completed postgraduate training in internal medicine at Harbor Hospital in Baltimore, and followed by infectious diseases, including transplant infectious disease at the University of Pittsburgh Medical Center. And then finally, critical care medicine at the NIH Clinical Center. He also completed advanced training in biostatistics and clinical research, including coursework at the Johns Hopkins Bloomberg School of Public Health, and is currently pursuing his Master of Clinical Research at Duke University. His clinical and research interests focus on severe infections in critically ill and immunocompromised patients, transplant infectious diseases, sepsis, outpatient parenteral antimicrobial therapy, or PAT, and antimicrobial stewardship. He has authored more than 25 peer-reviewed publications and book chapters, and has presented extensively at national and international scientific meetings. Dr. Hamad has held multiple leadership roles, including medical director of OPAT and home infusion at Washington University School of Medicine in St. Louis, and currently serves in national leadership positions within the Infectious Diseases Society of America, IDSA, including chair of the IDSA Practice Guidelines Advisory Group for gram-negative bacterial infections. Dr. Hamad is actively involved in medical education and mentorship and remains actively engaged in advancing evidence-based care for patients with complex infectious diseases. Welcome, Yasser, and the floor is yours.
Thank you for the generous introduction and for hosting me in this group. Assalamu alaikum. Hi, everyone. Hopefully everyone is having a good day. Today, I thought to talk to you about the hidden genome clinical and infectious insights from cell-free DNA. Personally, my first contact with human cell-free DNA was when I joined the NIH for my critical care training, and I learned it to be a fascinating and interesting concept that I will talk to you about today and see if I can convince you. Maybe starting with some hope. This picture I got from the social media this morning of a Sudanese airline landing in Khartoum, carrying passengers for the first time since the start of the war. So hopefully we continue to see signs of recovery, inshallah. This is my disclosures, and I will be talking about some off-label use of cell-free DNA and investigational use. So I thought during this hour we can talk about what is human cell-free DNA, elaborate a little bit of the history and evolution of its use in clinical medicine, and discuss some of its current and future potential applications. So I guess as the name kind of tells, human cell-free DNA are basically fragments of DNA molecules that are found in extracellular space, including plasma. And here, most of the studies I'm gonna be talking about are referring to the plasma cell-free DNA. Because of the presence of DNA in nucleases, usually it's present as small fragments and short fragments in the circulation, and they're not like in any membrane, so they're freely floating in the plasma. And they typically release into the circulation when there is tissue injury or normal process of apoptosis in healthy individuals, but with any disease process, and you get accelerated and increase of the release of cell-free DNA, and then where we kind of find some of its value. So let's go back a little bit to the basics. And talk about the DNA and the anatomy of the DNA. If we expand this picture a little bit here, you see in the bottom, that's the chromosome during mitosis when it's most highly condensed. And if you try to spread it apart and entangle it, you will find that the core component of DNA exists in the form of what we call the nucleosome. And the nucleosome, which is kind of the building unit of the chromatin, consists of 8 histone units. If you remember from your biochemistry classes, for me that's a long time ago. 8 units of histones with the DNA wrapping around it, usually around almost like 2 full wraps of the DNA around this core. And the red part here is the H1 histone, which kind of completes the second wrap, and it also helps in the DNA regulation. And if you try to look into more like a 3D kind of image of the nucleosome, you can see that in the middle here there are 8 proteins of the histone, 2A, 2B, 3, and 4, and then the DNA wrapping around it. And the DNA that's its wrapping is really very interesting phenomenon. Like it's as if you're bringing like a thread or a rope that's as long as a soccer or football field, and wrapping it into a less than 2 millimeter space. So it's such a very delicate and amazing process how we condense all this material and still able to use it within the nucleus. So when you look at the plasma, because of the nucleases usually tend to cut the DNA that's in between the nucleosome, and the nucleosome being wrapped around that histone actually forms some form of protection of the DNA in that unit. That's why most of the DNA we find in cell-free DNA, the length of it is about 166 base pairs, which is the DNA that's required to wrap around the nucleosome. And here in this graph here, you see the peak is around 160s for the cell-free DNA in the plasma. Sometimes you can have two nucleases still attached to each other, to dinucleosome kind of cell-free DNA. And in that case, you see a second peak that's usually small, around 300 base pairs. So before we go deeper, I guess I wanted to elaborate more about the distinction between human and microbial cell-free DNA, because many of you are familiar with some of the commercial, actually, microbial cell-free DNA that are used to diagnose infection. And in the USA, we use Carius, many centers. So this is microbial cell-free DNA, which is totally different than what we're talking about today, which is the human cell-free DNA. So the origin, as the name tells, so human cell-free DNA come from apoptotic or necrotic human cells, compared to microbial cell-free DNA come from bacteria, viruses, and fungi. And because microbes lack the histone, they don't get the protection. So usually the fragments are shorter compared to the 166 base pairs we talked about in the nucleosomal fragments. The sequence of human cell-free DNA matches the human genome, unlike the microbial. And the epigenetic modification that controls gene expression is done through methylation and histone modification in the human cell-free DNA, while the microbes use the methylation. And we'll come back to this piece later in the talk. The analytic challenge with the human cell-free DNA, the advantage is it's usually present in higher concentration, so making its detection easier. But if you don't separate the plasma from the rest of the blood cells quickly, usually what happens is the white cells will lyse, and that genomic DNA can contaminate the cell-free DNA and give you a skewed and inaccurate picture of what's happening in the body. While with the microbial cell-free DNA, usually they're present in smaller and lower abundance, and that's why they require sensitive methods such as next generation sequencing. Its clinical application, that's a topic we're going to talk about. So we'll talk about cancer biopsy, liquid biopsies, prenatal screening, and transplant monitoring. While in microbial cell-free DNA, it's basically used to diagnose infection, but it's also in research they used for microbiome profiling and different genera and species. Let's talk about the human cell-free DNA history and where it came into the picture. So actually early in the 40s, that was the first time they discovered the presence of extracellular DNA, because in the past, it's always known that the DNA is present in the nucleus. So in 48, Mandel discovered that. And then 66, they noticed that patients with lupus tend to have higher levels of cell-free DNA. So it was a clue that may be an indication of some tissue breakdown or damage that's happening. And then in the 70s, that's when they discovered that cancer patients have higher DNA level in the serum compared to the controls, which was a hint later for the use of circulating tumor DNA. But the biggest breakthrough really came in the late 90s by the discovery of cell-free fetal DNA in maternal blood by Dr. Low from Hong Kong. And that led to its clinical application in 2010 when it was approved for fetal chromosomal analysis and screening. So let's talk about the clinical applications of human cell-free DNA. Let's start with what we talked about last, which is fetal screening. So as the placenta develops, the chromoblast cells grow into the maternal uterus and interact to form the placenta. And as they form new blood vessels that tend to release fetal DNA, which can mix with the maternal blood. So if you take a sample from the mother, blood sample, and sequence it and identify the genes or the chromosomes and the DNA that comes from the mom and the part that comes from the fetus, and then map it to the different chromosome with simple ratio analysis, you can detect if there is more DNA coming from a specific chromosome in the fetus than it's supposed to be. And that can be a hint for diagnosing trisomy, for example, like Down's syndrome. And this is really a powerful tool. Imagine in the past that high-risk patients, for them to get diagnosed, they need an invasive procedure. They need amniocentesis, where you put the needle through the placenta, through the uterus, and through the abdominal wall of the mom to get a sample. And that can, while it's relatively considered a safe procedure, the complications can be up to 3% of pregnancy loss after 20 weeks. Other complications include direct and indirect fetal injury, continuous amniotic fluid leak, and risk of bleeding and infection. So you can significantly minimize that by using this cell-free DNA and screen the patients and risk stratify those who eventually need this invasive procedure versus those who can just be monitored without invasive procedure. So fetal screening using human cell-free DNA is a safer, non-invasive test, actually very precise screening test with the sensitivity and specificity of the high 90%, like 97% and 99.7 for trisomy 21 and other aneuploidies like 18. As well as you can actually detect some genes mutation using this method for certain diseases like sickle cell and other. And because of this work, actually, Dr. Low ended up getting the Lasker Prize in 2022, which is actually considered by many as the precursor or the step that precedes Nobel Prize. So that's like how significant this work is. The next use we're going to talk about is circulating tumor DNA. So by doing the same method, by detecting the cell-free DNA coming from the tumor, this can be used in early detecting cancers that are very small. After you do surgical resection, you can detect residual disease, and you can even monitor the progression of metastatic disease and do molecular profiling and see which mutations are happening and which therapy might or might not work, and assess the response to the therapy as you treat them with different biological agents and chemotherapeutic agents. For example, this uh, stage phase 2 multi-center randomized clinical trial that was published in the New England Journal of Medicine in 2022. They randomized 455 patients with stage 2 colon cancer into circulating tumor DNA guided management versus standard management. And the primary endpoint was 2-year recurrence-free survival, and they met their a priori determined non-inferiority margin, and the circulating tumor DNA guided management was not inferior to the standard management guided by clinical and pathological criteria. And when you look at the use of adjunctive chemotherapeutic agents, you can see that the circulating tumor DNA group actually got required half of the chemo that's used for the other group. And it was so significantly lower use of chemotherapeutic agents, while at the same time not affecting adversely the outcome. So in summary, circulating tumor DNA can be used as a potential screening tool and adjunctive diagnosis, as well as monitoring response to therapy, detecting acquired resistance, and early relapse. Before we move to the next clinical uses, I thought to kind of touch base upon one essential concept here, which is using the cell-free DNA as a molecular body scan. If you think about all these different body tissues and organs, they all carry the same DNA sequence. But the brain functions completely different than the heart, than the liver, than the kidney, or the intestine. So how can all of these tissues function differently while they share the same DNA sequence? And the answer is the epigenetics. And what epigenetics is, what determines which genes being activated and which gene being inactivated is one way the body does it by using methylation or histone uh, protein modification. And these two methods can determine the different genes that are activated within different organ according to its need. And if we find the signature from every tissue or organ, that what methylation patterns do they have in their DNA, we can actually create a methylation atlas that tells us when we take the DNA from the plasma, we can stratify it and quantify how much is coming from which tissue type. And this is really interesting. So by taking a simple plasma sample, you can scan the body and tell what is actually happening at that moment, because the cell-free DNA half-life is actually short, minutes to 2 hours. So that sample will tell you what injury is happening in the body during the last couple of hours, and which will give you a great information. So as a proof of concept, this paper from Nature 2018, they took healthy individuals and they did the methylation profile from their plasma cell-free DNA. And what they found is the majority of cell-free DNA in the plasma in healthy individuals come from white cells, about 55%. And then another 30% come from progenitor cells. And you can imagine these are tissue types that are actively multiplying and producing cells at the same time. They're in direct contact with the plasma, so they have the highest proportion. And then about 10% come from endothelial cells, 1% from hepatocytes and neurons, and then you have others, which include the other tissue types. But in disease states, this ratio will kind of vary depending on which tissue is being damaged or affected. So this is what we call the cell-free methylome sequence. That's what we just talked about. Another one is the cell-free ChIP-seq analysis, which is about chromatin immunoprecipitation. And this one detects the histone modification and can tell you which genes are being regulated, upregulated or downregulated in the specific tissue type. So it gives you even further information. So with that in mind, a couple of other general uses. It's before we talk about infectious disease uses. So cell-free DNA has been shown to be a prognostic marker in pulmonary hypertension. So in this study, they compared patients who have been risk stratified using clinical criteria, the REVEAL score, into low risk, medium risk, or high risk, which these risks have been associated with mortality. And then they measured the cell-free DNA on those groups, compared them to healthy individuals, and they found that as the risk goes higher, the cell-free DNA in the plasma goes up further. Not even that, they also found that cell-free DNA actually correlates with mortality. And they found that if you look here, the green line is the highest cell-free DNA tertile has the worst mortality or transplant-free survival, compared to the blue, which is the lowest cell-free DNA level, indicating there is less tissue damage, and hence they have actually the best survival. When they looked at the tissue-specific cell-free DNA coming from which type of tissues, they noticed that, again, similar to the total cell-free DNA here on my left-hand side, you can see the tissue types, including erythrocyte, progenitor cells, neutrophils, monocytes, natural killer cells, were higher than the healthy control. And in cardiac myocytes, the highest group have higher cell-free DNA than the low-risk group, as well as vascular endothelial cells. And on the right-hand side, this is basically the same information, but basically on every horizontal row here is a different tissue type, and every column represents a patient. And if you see in the top here, the purple is healthy individuals, the red is the high-risk group, and then the yellow and green are the low and medium risk. Just to make the contrast, if you block the middle group here and compare healthy on the right compared to the high risk mostly in the left, you can see a lot of red, which means a lot of higher level of cell-free DNA expression in different immune cells, as well as cardiac and vascular tissues, which kind of correlates with what's happening in those patients. So in summary, cell-free DNA is elevated in pulmonary hypertension patients compared to healthy controls. The cell-free DNA level increases with severity of disease and can predict transplant-free survival. And it's coming from tissues that make biologically plausible sites, such as inflammatory cells, because this is there, we think there is this inflammatory condition. On top of that, the cardiac cells and the endothelial cells, where the tissue injury is happening with all the high blood pressure and turbulent circulation. The next big use is about transplantation. And you can think of transplant, they kind of grasp the idea that if we can take the plasma sample from the mom and tell what's happening to the fetus, these are two genomic um, tissues in the same body. Can we use the same thing with a transplanted organ because they're genomically distinct from the recipient? So they started using the cell-free DNA as a way to monitor transplant rejection and injury. And the idea is, as you get the cell-free DNA, it includes both the recipient and the donor. And if you take the sample and do the sequencing and separate it, you can actually come up with the donor-derived cell-free DNA. And they detected thresholds for which that correlates with worse outcome or significant injury. For example, in lung transplant, consider more than 1%. So if the more than 1% of the total cell-free DNA is coming from the donor tissues, which is the transplanted lung, that tell you that there is active tissue damage, and you need to figure out why that's happening, and do further investigations or treatment. And when we talk about transplant, we can see this is a study by Solina in 2016. They looked at thousands of patients who underwent transplant between 1990 globally to 2013 and looked at their outcome and mortality. And you can see here the lung is actually trailing the other organ transplant, the kidneys and the heart. They do relatively good, but the lung does poorly with a 5-year, with a 50% survival. Their half-life about 7 years or so. And the major driver of that is rejection. And rejection in lung transplant lead to what we call CLAD, which is a chronic rejection form. And that's why many of the transplant focus has been how do we prevent rejection, and that's why cell-free DNA comes handy. So chronic lung allograft dysfunction is if you have a lung transplant provider, that's the number one fear they worry about, which is the chronic form of rejection that's progressive, irreversible, decline in allograft dysfunction. And once that sets in, then the mortality even falls down further with the worst outcome, with 50% of them die within the next 3 to 5 years. So it goes even down steeper. And it has two forms. You have the bronchiolitis obliterans syndrome, the BOS, that's the most common component, which is shown here in this picture. You see the bronchioles are getting thickened and inflamed and proliferated, leading to obstructive pattern. And then the other form is called RAS, restrictive allograft syndrome, which is more like a restrictive fibrotic function of the lung that also have actually worse outcome. So that's why I think you will see that some of the studies we're going to talk about, the transplant field, they focus mostly on how to use this technology to diagnose rejection. So in this study, for the starting with heart transplant, they used the cell-free DNA. This was from UCSF or Stanford, sorry, in 2011. They found that actually cell-free DNA correlates very well with rejection. Basically, they used the same method, quantified what comes from the donor and recipient. And not even that, they said even those who are close to rejection, there was a trend for a rise in cell-free DNA. This was verified or duplicated by the NIH group, which I will talk about it in the next slide. And they saw that the cell-free DNA in heart transplant detected rejection with an area under the curve of over 90%. And it's more better with the antibody-mediated rejection, which is a worse form, harder to kind of treat than the acute cellular rejection. But both of them around 90% area under the curve, and correlated with disease severity, correlated with drop of EF. So since we talked about GRAFT, so GRAFT is the Genomic Research Alliance for Transplantation. It was established in 2015 by the NHLBI. And it contained, they basically collaborated with transplant centers in the area: Hopkins, University of Maryland, Innova, and MedStar, Washington Hospital Center, as well as others. And they got all their samples. They follow now over 720 patients post-heart and lung transplant, and do preset time points, cell-free DNA measurement. And a lot of the studies I'm going to be talking about are going to be from that group. So we talked about the heart. What about lung transplant? The same thing. It actually have very high sensitivity, and it detects rejection about 1 month to 3 months prior to the actual clinical rejection time. So it can help you avoid the damage that happened during rejection by detecting it earlier, giving you a chance to treat early and prevent damage to the lung transplanted organ. And actually, since it's non-invasive, during the COVID, a lot of centers reverted to using cell-free DNA because they didn't want to bring their patients for bronchoscopy. And these patients usually they get bronchoscopy on a scheduled time, and every time they do bronchoscopy in the first year, for example, every month for the first 3 months, and then every 6 weeks or 2 months for the rest of the year, and then thereafter for any complication, they go in and they do biopsies, and these can be associated with, you guys have seen, complication of bronchoscopy like pneumothorax, bleeding, pain, hypoxia. So by using cell-free DNA, which is a non-invasive test, you can actually avoid a lot of invasive procedures, a lot of complications, and only do the procedures for those who need it. Rejection actually can be very difficult to diagnose at times, because sometimes it can be a sampling error where you take the rejection is happening in only certain foci, and by doing random biopsies you could miss it. And not even that, even if you get the right area, many times there is inter-observer variability in reading the histology. So by using a highly sensitive test with high negative predictive value, that's over 96% if you use like a 0.5%, or 90% if you use less than 1% as a cutoff for donor-derived cell-free DNA, you can help diagnose patients early and at the same time avoid a lot of invasive procedures. And after COVID, actually, many transplant centers, including Hopkins, they did not go back to the regular bronchoscopy, and they only did the bronchoscopy for those with high cell-free DNA. So that actually made a big difference in the real world. So now coming back to our interest here, which is infection, how can the cell-free DNA help us diagnose infections post-transplant? In this group by Graft, they noticed that it's not only rejection that causes high cell-free DNA. Actually, infection can also cause increase in high cell-free DNA that's not statistically significant from acute rejection levels. And that's when they looked at the different pathogen categories, and those who have a pneumonia, for example, in respiratory viruses, which here kind of they use FEV1, which is for respiratory volume 1 second, a PFT parameter, kind of indicating like pulmonary infiltrate and pneumonia. It was much higher than those who did not have a pathogen, or those who have no pneumonia and just a virus, upper respiratory viral infection. They also then looked at high-risk pathogen post-lung transplant. So these patients who underwent bronchoscopy based on their old protocol, and they got cultures, and they found they have been linked between certain infections and subsequent development of chronic lung allograft rejection, which is a chronic rejection form in lung transplant. And they looked at those pathogens that has been linked to that compared to pathogens that are not usually associated with chronic or subsequent implications, including the respiratory viruses. The respiratory virus has been actually a very notorious for eliciting rejection and chronic allograft dysfunction. And they found that the high-risk pathogens had much higher donor-derived cell-free DNA than the low-risk pathogens. And the same also for high-risk bacterial as well as viral pathogens. And then they found that among the donor-derived cell-free DNA was higher among microbial isolates that have concurrent abnormal histology. So when they did the biopsy, they found those who have acute inflammation, for example, or diffuse alveolar damage, other than rejection. This is non-rejection findings. So if they have a pathogen plus signs of inflammation, which indicates active injury from infection, the donor-derived cell-free DNA was higher in that group compared to those who did not have abnormal pathology. The other thing also is, which we'll talk about in the next slide here, in this other study, what they did is they said, okay, what if we measure the cell-free DNA at the time of injury? Can that predict subsequent development of either chronic allograft dysfunction or worse outcome? So they looked at about 40 lung transplant recipients with respiratory viral infections and followed them for a year. And their hypothesis is that donor-derived cell-free DNA will predict worse outcome for those who have high level. And then they separated them by looking at those who have high level of cell-free DNA, which is more than 1% versus normal. And then they followed them over time. On my left-hand side here, you can find the donor-derived cell-free DNA over time. You can see this is time 0 when they did the study. I don't know if you guys see my mouse here. And then at their baseline, the level before that, both of them actually were the same. But the subsequent levels, the patients who had high level of donor-derived cell-free DNA, actually took them a really long time to kind of normalize. And not only that, they looked at their pulmonary function test and used forced expiratory volume in 1 second, which is a measure of the lung function and the health of the transplanted organ. So times 0, those with high donor-derived cell-free DNA, they had a much significant lower and worse function in the lung. And that actually persisted for up to 1 year. The dashed line here with the low donor-derived cell-free DNA actually went back to normal by 90 days and stayed normal, while this group continues to do worse. When they looked at the primary outcome, which was death from respiratory failure, as well as retransplantation or CLAD, progression to CLAD or CLAD progression, it was more significantly happening in the group with elevated donor-derived cell-free DNA, and that was statistically significant. So when I joined the group, and I was kind of interested in infections and how we can use that to diagnose infections or help us, for example, differentiate between active infection, invasive disease versus colonization, for example. So I thought to study the concept for fungal infections. So maybe I thought we'll do some clinical vignette just to kind of show you the complexity of these patients. I'm sure many of you guys deal with them. So we have this 57-year-old female with history of CHF and COPD, end stage, underwent lung transplant over a year ago. She came in with shortness of breath and leg swelling. They did a diagnostic bronchoscopy with biopsy, and unfortunately, she developed pneumothorax from that. The BAL grew aspergillus species. Her other history, she's been relatively stable, getting her immunosuppression regimen, no recent augmentation of the immunosuppression, no boost in that. There was no, the biopsy came back negative for rejection. She's afebrile, normal white cell count. Would you treat her with antifungal therapy? So the idea is that these patients are complex. They have multiple things happening at the same time, and their lung findings can be abnormal from so many causes. And if you look at the guidelines by the JHLT General, ISHLT, which is International Society of Heart and Lung Transplant, as well as adopted by IDSA and the mycosis study group, to diagnose aspergillus infection post-transplant, you need really to fulfill a complex set of criteria, including clinical, microbiologic, and radiologic criteria, as well as histopathology if you have that. And in these patients, even if though you have a radiologic finding, it might not necessarily be due to infection, and some infection can be subtle and not have a significant injury. So it can be a mundane task. So we thought, how can the cell-free DNA help us risk stratify these patients, at which patient is more likely to do worse versus do better than the clinical criteria? So we identified patients who had lung transplant and aspergillus isolation, and then who at the same time have cell-free DNA collected at the same time of the infection or around the time of infection, then did the sequencing and identified the donor-derived cell-free DNA. So out of 177 transplant patients, we identified 34 patients who had aspergillus infection. And then basically these 34 patients, we classify them by using the typical clinical criteria that we talked about, using clinical signs and symptoms, radiologic findings, and microbiology criteria, as well as separately doing a molecular criteria. So we thought those who have donor-derived cell-free DNA more than 1%, which is significantly high, would consider them as molecular positive or invasive disease, versus those who have normal or not elevated donor-derived cell-free DNA would consider them as colonization molecularly, versus the clinical classification. And then we looked at transplant-free survival on using these two criteria separately. What we found is that the molecular invasive aspergillus, based on the cell-free DNA marker, have a much worse clade-free survival, which is survival free from chronic rejection, that was statistically significant. While the clinical invasive disease, by using the established guidelines, while the hazard ratio was high, it was not statistically significant. And more interesting is the breakdown of patient and the interaction between the two criteria, even though the numbers are small. But if you look at my left-hand side here, so here is the clade-free survival by different groups. These are the 4 different scenarios. So the blue represents clade or death. The orange represents people who did well and had clade-free survival. So if you look at the first group here, people who met both the clinical criteria and the cell-free DNA criteria, the mortality was almost 70% in this group, mortality/chronic rejection. In the further right, people who did not meet none of the criteria, so by clinical criteria, they considered colonization, as well as by molecular criteria, they had 0 mortality or progression to clade during our follow-up. In the middle, these were the discordant groups. So patients who met the clinical criteria, so you would kind of consider them that, these are having active disease based on the guidelines, but have negative cell-free DNA, only 14% of them went on to develop clade or die during follow-up. While those who actually considered colonization based on guidelines but have a positive donor-derived cell-free DNA have a 50% mortality or progression to clade. So it tells you that even though the numbers are small, but it's shifting the risk quite significantly based on the donor-derived cell-free DNA, even among clinical colonization group. So then we kind of wanted to depict the donor-derived cell-free DNA over time, and we noticed in molecular criteria that people who have elevated donor-derived cell-free DNA at the time of Aspergillus infection, which is my right-hand side here, they started having a rise kind of almost like about a month or maybe more before the event, and continue to have an elevated donor-derived cell-free DNA compared to the people who have lower cell-free DNA that stayed low. While just going by clinical criteria, there was no separation between the two groups in terms of cell-free DNA. And in summary, in this study, we found that cell-free DNA identified patients with worse clade-free survival, better than clinical criteria. But I guess the questions remain: are these findings due to subclinical injury or an alloimmunization that's happening in these patients? And even though we found no significant difference in the rates of rejection between the two groups, but maybe something happening at the background there causing them to elicit more immune response and damage on top of the lung injury. But if the injury was happening actually from the aspergillus, and that's eliciting all this damage and subsequent worse outcome, would earlier treatment lead to prevention of this worse outcome? That's one question. And the second question is, should we also treat them with immune suppression on top of the antifungal once we get the infection under control to prevent this immune activation? So these are still kind of unanswered question and need validation studies and additional studies to confirm that. So in summary, cell-free DNA in post-lung transplant infections was higher among high-risk pathogen compared to low-risk pathogen. Elevated cell-free DNA at the time of respiratory viral infections was associated with worse outcome, as well as elevated cell-free DNA at the time of Aspergillus infection was found to be associated with worse outcome. So next we're going to talk about one non-transplant study, which was about COVID, using cell-free DNA infection monitoring in COVID infection. This was a study done in early COVID days, published in 2021, JCI, the same group, and they looked at cell-free DNA during COVID. They monitored it preset times from admission to discharge, and they noticed kind of interesting trends. So let me zoom on a couple of patients here. So here is tissue level cell-free DNA on the right with different colors, and this is the concentration. And these are two patients who did not do well. They both died during admission. So two things you can notice. One, there is significantly elevated cell-free DNA in this patient. Usually the normal level is 10 to 30. This patient is having 1,000 and 1,500 total cell-free DNA, which is a quite bit of a tissue injury that's happening to this patient. And you can notice that while they did have an improvement initially and they had a decline, then they did have this rebound and they went up to very high levels before their death. And one suggestion is, I guess that's why if the cell-free DNA by itself is acting as a damage molecular associated pattern, which can promote additional inflammation. And I guess that's why kind of the steroids, I guess maybe that's why the steroids are showing some benefit, because they kind of dampen that second rebound inflammatory response that's probably fueled not by the virus, but by inflammatory cells. And you can see the majority of the cells here are inflammatory cells, including neutrophils and monocytes and other inflammatory cells. And compare those to two patients who relatively did well. So you have two patients who survived, who one, while they had higher levels, it was relatively much lower than those levels, so like 400, 500, here 150. And then the levels kind of just plateaued and went down as they recovered from their disease. And here, basically, the same figure depicting the different tissue types and the amount of cell-free DNA. And on the top is each color that represents the different categories. So black is COVID, and then the blue is healthy controls. And you can just notice that, sorry, from the blue here compared to the black, there was more red on the black, which indicates higher level of tissue-specific cell-free DNA. They also noticed that the cell-free DNA on admission was associated with outcome. So this is non-hospitalized COVID patients, which is great, versus hospitalized who recovered in blue and hospitalized who died in red. And the total nuclear cell-free DNA, as well as many tissue types, including inflammatory cells, vascular endothelial cells, adipose tissue, and hepatocytes, were much higher among those who end up dying. This is way before they started having the rebound. Like even from admission, you can risk stratify those at higher risk of dying versus those at higher risk of or have lower risk of more chances of survival. So in summary, cell-free DNA in COVID patients identified that there is a significant tissue injury happening in COVID patients and release of cell-free DNA from diverse tissue types. And then cell-free DNA during admission can risk stratify those who's going to do well versus going to do worse. And elevated cell-free DNA can mechanistically trigger and propagate tissue injury through propagating inflammatory response in these patients. However, cell-free DNA does not come without limitations. So some of the limitations are pre-analytic. So for you to get accurate readings, the plasma has to be separated from the cells and the blood cells by usually less than 4 hours to prevent lysis of the WBCs and releasing of genomic DNA into the plasma, hence contaminating the picture that you're trying to draw from the whole body and get it more skewed toward just the contamination from the WBC DNA. And then the second is about the relatively large volume of plasma needed. So to do really the tissue-specific analysis, you need about 1 to 2 mLs, which can be really a big of an ask if you're trying to approach like a biobank and ask them to get you some samples. Usually they're happy to give you 100 microliters or something. In addition, it has relatively limited specificity because while it's elevated in rejection, it can be also elevated in infection. It doesn't tell you which was the cause. Although further development, including the pathobiology and the ChIP-seq, for example, hopefully might give insights in the future by giving a map of which genes are being activated. And then access to testing and cost, because it's relatively focused on a couple of vendors for rejection detection. There are 2 companies that are doing this now clinically and offering it to transplant centers, and but at a higher cost. Potential areas for testing. So if we use this molecular scan, can it help us, for example, identify sources of occal bacteremia? Patient with Staph aureus, many times we don't know where it came from or where it's seated. Can we do the test to help us identify which sites are having more damage by the bacteria and hence help us kind of focus our effort of diagnosis? And then can we use it also to detect or distinguish between active invasive disease versus colonization in slow-growing bacteria, for example, non-tuberculous mycobacteria, and help us stratify those who needs to be treated versus not. And then future, as I said, the ChIP-seq analysis can help with gene expression, and hopefully it can expand its use. With that, this is the picture of the laboratory of applied precision omics, the graft study people from the NIH. In the middle here is Dr. Shan Akbar, He's actually originally from Cameroon, and he came and finished his training in the NIH and then stayed. And he kind of leading the group here with the graft, and he's a lung transplant physician. But it's really a big group, including basic scientists, clinicians from different backgrounds, including cardiology, lung, pulmonology, critical care, infectious diseases, and hematology, oncology. And it's been really nice group to work with. And with that, I will I'd be happy to take any questions you guys have.
Thank you, Yasser, for
Stop
the
sharing.
excellent and interesting presentation. Actually, this concept new to me. I have not um, um, heard about it or used it before, but so I have many questions for you, but I will maybe do two questions and ask people to ask also. So my first question is, do you see anyone tried or have envisioned using the cell-free human cell-free DNA in addition to the next generation genome sequencing to try to you know make both testing are more accurate and more specific to diagnose infection specifically? That's the first question. And then the second question, how about any role in antimicrobial stewardship? Anyone, or do you see we can use this method to guide antibiotic duration and de-escalation, especially in severe sepsis or severe infections?
So first, thank you, Zadine. Yeah, I think it's really I think outside transplant, really in medicine, adult medicine, of course, the OB people are using it all the time. Like during my last uh, son, like my wife last pregnancy, they actually did that test, and it was kind of interesting to see. So, but in the adult world, it's I think outside of transplant still has limited use. But I think that's a good question. The first question about the combined use. I mean, from a technical standpoint, it's doable. You can, but you need to do it with as the next gen sequencing. So if you sequence the whole cell-free DNA, then that's what actually they do. What they do, for example, these commercial carriers, they sequence the cell-free DNA in the plasma, and then they separate the human genome and just disregard it, and then focus on the non-human and try to do all their work on that. So theoretically, you could also then analyze that cell-free DNA and do the tissue specific and quantify it. I think it has to, it will give a lot of information, but it has to be standardized. And as I said, for example, they need to collect the plasma in a certain way to prevent that contamination and so forth. And I think as more studies come and give more light and value of it, I think that might be more interesting for these agencies to work to invest in it, because I think it's going to need for them to do a lot of effort and work to report both. The second question about using it for as a stewardship tool, I think that's interesting. I actually was interesting to study it in Staph aureus bacteremia, and I reached out to do like biobanks, and both of them they said, "Oh, that's too much plasma you're asking for," and the other one has very like all samples, and the quality was very poor, so we couldn't do it. But yeah, I mean, if we find that the cell-free DNA normalizes after 1 week, do we need to give them 6 weeks or 5 weeks, or depending on the indication, or can we give it shorter? I think that needs to be studied. Like, if it's normalized, can that be a sign that actually there is no more tissue damage, as well as looking at there was actually a study of microbial cell-free DNA and Staph aureus bacteremia, and they correlated with outcome and things like that from Duke by Dr. Fowler. But can we combine it with the tissue injury and then use the two to kind of figure out when we can safely stop therapy? I think that's definitely a valid study that could be done and validated for that reason. Yeah.
Thank you very much. I think Ahmed Abu Bakr has a question.
Thank you very much. Yes, it is really very interesting topic, and um, oh, I guess learn about this topic recently. People are using this Kairos test. You know about it? Is to see if there is any bacteria in the blood. Once they
Right.
have negative blood culture, I think it is the same concept of cell-free DNA. But my question, what do you think about it? Is if you can do it in lung transplant, have you seen any use of it in different transplant? I moved from Michigan to Texas. I'm working in an institute where they do mainly liver and kidney transplant. Have you seen use of it in kidney and lung transplant, or it's just mainly on the lung transplant?
Yeah, I think there is many studies in kidney transplant, and they use kind of sensitive markers. Uh, I think the kidneys, because I guess there are so many ways you can monitor it. I guess the urine output. I don't know if they use it as regular as the heart and lung people.
I see.
I definitely like. I guess maybe I'm biased because I work mostly with the lung transplant patient. I've seen them using it. Even when I moved here to Minnesota, the group here is also have been using it for many years. So I feel the lung transplant community definitely picked up on this, and now they're using it as a primary screening test in many big centers. The kidney, as I said, there is so many data on that, and it's actually very also accurate with different cutoff points, uh, and it can tell you like if there is injury happening. But I'm not sure about their protocols, how often they use it. Probably use it earlier in the post-transplant period, but then later on, as long as everything is stable, with the test being expensive, it kind of becomes like benefit or cost effectiveness, I guess.
Thank you. Yasser.
Sure. Yeah.
شكرا ياسر. Any idea about the cost, like average cost?
I know it's expensive. I don't know about after insurance and all that. But for the even for the research studies, because it can cost like few $100s at sample. For if you're doing like the detailed tissue specific analysis. I think if you just do the total, it's relatively cheaper. But if you're gonna do the tissue specific analysis, I think it's like 500-600 something up to 1,000 depending on the lab. But these are not commercially available. These are like really sophisticated labs. But the commercial lab, I think, as it's becoming used more often and more disseminated, and that is actually being FDA approved, I think the cost over time is going to go down as more competitors come into the field and use it more often.
شكرا ياسر. And in terms of time to result, like from sample to result, how long it takes for these guys to report it?
I believe it's a few days. From talking to my colleagues from the transplant, because they use the commercial test. So, which is probably not very reasonable. I think comparing it to the microbial cell-free DNA, I think also the turnaround time is, I don't know if you guys use the carriers, also a few days. So I think, yeah, it's still clinically applicable. I guess if you're dealing with something pretty acute and you need to make a decision now, I don't think that's the right test. But if it's something that you're dealing with that can wait a few days, outpatient or kind of unequivocal, I think it will be useful clinically. But as of now, I think its use for infectious diseases is not quite ready for prime time yet, unless we establish more evidence that it actually correlates with outcomes and with different clinical conditions.
Thank you, Yasser, for the excellent presentation and the engaging discussion. And thank you all for attending today. And we'll see you in April, inshallah, we're gonna skip next month due to Ramadan.